Thank you, John. I think John said it all. I just have to leave now because I have nothing more to say. Thank you, the Transform Team 2014. Thank you, Opportunity International, for giving me this opportunity to be here in front of all of you. I'm really honored. Let me tell you a little bit about the network that we belong to, that I belong from Healing Fields Foundation, the beautiful Opportunity International Network, which is a nonprofit global network of over 50 local nonprofit organizations around the world. Opportunity, the way we work in Opportunity is slightly different. We provide microfinance loans to poor women where they could set up their micro enterprises to earn a living, but we don't stop there. What attracted Healing Fields Foundation to be part of the Opportunity International Network was the dignity and purpose of life that they saw in the women, in the poorest of the poor women, across 22 countries with about 17,500 employees. They provide microfinance, as I told you earlier, plus they provide capacity and train women in business leadership and also train the nonprofit organization leaders by building their capacity to be able to provide these services to the poor women. They did not stop with just microfinance loans and doing microfinance, the business enterprise capacity building, but they also went beyond that. At Opportunity, we believe that financing alone is not enough. We need to be able to provide more than finance, health, education, meaningful livelihood, which is realistic to the women to be able to help them come out of poverty. In India, and for that matter, everywhere in the world, we are facing crisis. The enormity of the crisis is different for each of us. And I will share what it means to us in India in terms of healthcare, in terms of healthcare for the poor, because that is where I work in, and that is where we, Healing Fields Foundation and Opportunity work. We cannot deny that this healthcare crisis that all of us face is not localized. The answers and solutions at a generic level could be used across the universe. And we talk about two important aspects. I've heard a lot of people here in the United States talk about two important aspects: access to healthcare and affordability of healthcare. And the same issues we back in India face, access and affordability, but at different levels. Let me set the stage for you with a few facts from India, because I would be better off speaking about India. 25% of India fall into below poverty line with just one incident of hospitalization, and the hospitalization could cost as less as $100 to $150. 80% of our healthcare expenditures in India is out of pocket. 60% of the child deaths is because of preventable health issues. Almost less than half of the children in India are malnourished under the age of 5. 600 million defecate in the open. That is a little more than the population, 50% more than the population of India. Majority of the women don't have access to sanitary napkins. This is the one extreme of the health continuum that we talk. India, to me, is a microcosm of the world. We have the poor, we have the rich on the other end. And I keep hearing all jobs being outsourced to India. We need to stop that. But with the outsourcing of jobs to India, what it has done to us is it has brought in affluence. The middle class has been rising. And with that, we have also imported, thanks to the technology, thanks to the movement across nations, we have imported some of the eating habits of the West as well. So, we are the third most obese country in the world after the United States and China. India is fast becoming the diabetic capital of the world. The growing affluence and the education, as most of you would agree, does not guarantee the knowledge of good health, either here or back in my country, in India. So what do we do? What is our solution? And the solution that we are talking about is not necessarily just for India. It can be adapted, it can be used across the whole spectrum. There are three critical elements that we have incorporated in our work. One, health education. Second is health financing. And the third one is community collaborations. And this can be taken anywhere across the world and adapted, not just in the developing world, but I believe that we can outsource this to the developed world as well. The first and important rule that we set ourselves, and even till today we set ourselves when we go into the community, is to listen. We wipe our minds off. We blanket, we go with an open slate to the community, to listen, to understand. Many a times as educated people, as people who we think that we know all there is to know about how to come up with solutions, how to tackle the healthcare crisis, do not understand the reality of the poor, reality of the women in the villages, nor do we understand what their priorities are. So the first rule that we follow is go in with a complete clean slate, listen to the women, listen to what they want, listen to their needs, listen to their priorities. I'm going to tell you a story. I love stories. And these are real stories from my women in the remote villages from India. As I told you earlier, almost 600 million people defecate out in the open. So what do you think is the solution? Build toilets. So we have a huge government subsidy where they build toilets. There are microfinance loans available to build toilets. So when we started our work training microfinance women to be community health educators in the community, the public health engineers came to us and said, you know what? The last couple of years we have built toilets, but none of the toilets are being used. So we went into the community and started talking to our facilitator as to why the toilets were not being used. And the answer was, this cluster of villages, every year during the monsoons would get flooded. Flooded where we could not go in because there was waist-deep water. And most of the women there were microfinance members, and they had cattle because they had got loans and they had bought cattle, and the cattle provides an income even during the rainy season. So they needed a dry space to store cattle feed and grains. So where do you think they did? They had a beautiful concrete structure. So they put it all in. And they're used to defecating out in the open, and that is not a priority. So the next year what we did was, we started talking to the community just before the monsoon and motivating them to create dry spaces for the cattle feed and the grains so that they can continue using the toilets, because our objective was to stop open defecation. That was our priority. Their priority was safe place for their cattle feed. So we need to look at the reality, understand their priorities before we are able to start any kind of work. So our community health facilitators not only understand the community, but also teach them about nutrition, sanitation, hygiene, first aid, linkages with the government program, linkages with the private providers. She becomes the walking, talking, breathing health wiki, because they do not have Google, they do not have networking, they do not have any way to get information on health. So therefore, our women whom we train become the walking, talking, breathing health wiki and the first responder to any kind of health crisis in the community. The second element, in spite of doing our preventive education, most of you know, we still fall sick. We fall sick, and we need to go into a hospital. And who's going to finance? So we came up with a health insurance program. And the health financing can come in 3 ways: insurance, savings, and loans. So we were one of the pioneers in coming up with need-based health insurance program. And then we realized health insurance is useful when you have infrastructure, when you have a hospital. What do we do when we don't have a hospital? And what do we do? Because in India, insurance pays only for hospitalization. So and 70% of the illnesses are preventable. And the poor did not have money to go and access outpatient care. So we needed to provide small monies at the community level to be able to break the cycle right then and there, and created health savings groups where women saved some money, very small amounts of money, and could take a loan of $5 to be able to access quality health care, medicines, and diagnostics. And this is within the control of the community at the village level. And tying back into listening and understanding the reality of the community, and be able to find a solution which is appropriate and practical in the community, is what we need to understand and apply. And just financing alone is not enough. We have to couple it with the health education so that they do not go back, or that particular illness, if it is preventable, does not reoccur, or if it reoccurs, how are they able to handle it within the community. The third critical element, and I think that is one of our biggest pillars and one of our biggest successes, is collaboration. We are great believers in collaboration because we really can't do everything all by ourselves. We need to be able to create an ecosystem. And our collaborations has a dual purpose. The first purpose is to be able to provide access to different products and services that is available to you and me, to the rural villages, which is remote. And the second one is to provide income to the women that we train so that they can continue their work in the community. Let me tell you a few examples on this. We partner with the local resources that's available in the community. It could be private health providers, it could be the government public health providers, it could be private businesses, it could be microfinance institutions or other nonprofits that work in the community. Most of them have a common goal, but all of us love working in silos. If all of us came together and converge and be able to bring all of our strengths together and pour it into the community that we are working, I think the transformation would happen. And our community health facilitators, who are the poor women in those communities that we have trained, are the convergent point for us. We have tied up with a nonprofit eye hospital in a remote area in a state called Bihar. And the vision, their treatments were not available to the community, and they had to travel about 100 miles to be able to see an eye doctor in Patna, which is the state capital. So we trained our community health facilitators to be able to mobilize and be able to conduct health camps in their community, and the doctors from the eye hospital would come in to support and give the treatment. The women were trained to do vision testing in the schools as well as in the communities and refer them into the hospital. And during the eye camp, which happened in the villages, they would be able to get subsidized eyeglasses for a fee. And our women would get a commission out of it so that that would help her continue to be able to do her work. This is a great example of a collaboration with a nonprofit eye hospital that we had. As part of our education, we teach adolescent girls and young women about menstrual hygiene. Things that we, not only here, but also in my country, at an urban level, at an educated level, we take for granted. Women still continue, 80% of the women still continue using cloth, cotton cloth, during menstruation, and many a times it's pretty dirty because they don't dry it out in the sun. They dry it out in, wash and dry it in dark corners in the house because there's a whole lot of superstition attached towards that. So we said we need to solve this problem because there's a lot of hygiene issues, and because of that there are a lot of health issues. And the sanitary napkins that were available in the market was too expensive. So we had to identify a private enterprise, set up a private enterprise, which would be profit-making, because we do not want charity. Like I told you earlier, as part of the Opportunity International Network and as Healing Fields, we do not believe in handouts. We believe in hand-ups. So we need to create enterprises, and which we created a sanitary napkin manufacturing unit and used the 1,700 community health facilitators that we have trained to work in as many villages to be able to become the distribution platform for these sanitary napkins and other products and services to the community, which could not access these earlier. So they could do it within their villages. And of course, for the work that the community health facilitator put in, she earned an income. So we basically created an ecosystem around our community health facilitators for the community and the resources available there to be able to support and help her to sustain the work that she was doing. Finally, for the last 17 years that we have been working in the remote parts of India, there are two important learnings which are very dear to me. And that is what I want to leave you with. The seemingly impossible is possible. Because when I talked about the crisis, it was like there was no solution. There is a solution. The seemingly impossible is possible. And who better than women to make it possible? Thank you.
Great stories. Yes. And in terms of possible and impossible, you described how you encourage in a particular village, you create incentives for people to completely change their orientation about something as private and filled with tradition and habits that were handed down from generation to generation, like menstrual hygiene. How does that scale beyond an individual village? And do you envision the day when, broadly speaking, women in India will take for granted the kinds of hygiene practices that educated people in India and people in the developing world do?
Yes. We train one community health facilitator per village. Today, we started with 50. Today, we have 1,700 community health facilitators working in 1,700 villages. And by next year, we're going to double the numbers. Yes, it is possible.
And does the mechanism of this particular success that you've had with menstrual hygiene, does it work on other things? Does it work on other kinds of, and are the women always the drivers here?
Yes, I believe that women are drivers as far as healthcare is concerned. Anywhere in the world, women are the influencers. What you and I eat is because of what our mothers and wives have provided us and cooked for us in the home. They don't give us burgers and fries. They make sure that we eat healthy food. So when we educate the women, they being the health influencers in the community, in their own homes, make all the difference and will make all the change. And that is why our focus is to train women as not only health facilitators, but also being the first responder to any kind of health issue within the community.
So women teach young people about health and about food, and men teach them about smoking and guns.
Mostly, yes.
Yeah,
you're right.
pretty,
You're
yeah.
right. See, the women occupational therapists got you to be mobile,
Correct?
right?
Yep.
So that's where it is.
Are the men in the way?
The men are in the way. I love the men. I have a husband, I have a son, and I have brothers, and I have brothers-in-law, and I have male friends. In India, a woman, fortunately or unfortunately, are not complete with a man, without a man. The first priority, like when we started, let me just tell you when we started, what happened. When we started focusing on women's health, reproductive health, maternal health. And I still remember about 8 years ago, when we first moved from health insurance into community health education training, a group of women in my first batch of community health facilitator training came to us and said, great, you're talking about women, you're talking about pregnant women, mothers, and adolescent girls, and children below 5. What about the men? What about our sons? They also have illnesses. They also need nutrition. What do we do? And another example, there was a huge government program, huge program in our country, a bilateral program, where they provided food supplements to the pregnant mother and the lactating mother, nutrients and oil. And the women would troop in with their vessels, with their bottle, with their vessels to collect the oil, which was enriched, and the flour. And what did they do when they came back home? They mixed it with the rest of the flour, with the rest of the oil that they had, which was supposed to be a food supplement to be able to give additional nutrition to the pregnant mother, was mixed up with the others. So in India, family becomes the crux. The woman is the center of the family, and as anywhere in the world, the woman usually becomes the last person to take care of her own health. And the man and the sons and the rest of the family are important. So it revolves around her.
Do you see the leader of India, Mr. Modi, encouraging these kinds of things in India? Or do you see this new administration and new approach to governance only about bullet trains and kind of Chinese-style showpieces? I'm going to get you in trouble here.
Yeah, you are getting me into big-time trouble. Okay. Mr. Modi has been there for just 100 days, just over 100 days. He's been talking the right things about building toilets. He's the one who said that we have more cell phones in India than toilets. And he's the one who said that he was going to transform and build toilets. And he's been talking he also spoke on the Independence Day about respecting women and inclusiveness for women and be able to include them into everything. So we will wait and watch. We never lose hope. We will hope for the best, and I'm confident that it will happen.
In any case, we know that there's at least one person who's going to hold him to account.
Of course, yes. All of us, all the women will hold him to account.
Thank you so much.
Thank you.
Thank you.
That's really huge. It's very good.